November is National Epilepsy Awareness Month, and in honor of that, the UC Gardner Neuroscience Institute will be hosting a special Epilepsy Symposium on Saturday, November 2nd from 8:30 to 12:30. For more information on the event, visit uchealth.com/events/epilepsy2019. And be sure to send in your questions, and Dr. Privitera will answer them live during this segment. So Dr. Privitera, to get started, for those who may not know, what is epilepsy?
So epilepsy is a disorder of the brain that's characterized by recurrent seizures. A seizure is caused by an abnormal synchronization of neurons in the brain, and then it causes a clinical symptom. So if those neurons are, for example, in the motor area, you may see twitching of a hand or twitching of an arm. If they're in the speech area, somebody may have loss of the ability to speak. Other kinds of seizures, and the most common type that people understand is a grand mal seizure or convulsive seizure. Those involve motor function in the entire body and cause alteration in awareness, and then a period after the seizure that's called the postictal state, where people are unresponsive. But there are many different types of seizures, and again, it depends where in the brain and how much of the brain is involved. That'll determine what the seizure actually looks like.
And so to pick up on that, what is the difference between a seizure, epilepsy, and a seizure disorder?
So a seizure is a single event, and it can be caused by a variety of different things. If you have recurrent seizures that aren't caused by a specific trigger, for example, traumatic brain injury or something like that, then recurrent seizures would be defined as epilepsy. Now, many people don't like to use the term epilepsy, so some people call it a seizure disorder, but from a medical perspective, seizure disorder and epilepsy really are the same thing.
And as a physician, how do you diagnose epilepsy?
So as physicians, the most important thing actually is the history. So we want to hear what happened at the beginning of the episode or during the episode. And very often the person with seizures doesn't know. So it's always important when somebody with a seizure comes to see the doctor that they bring someone who's watched that person have a seizure. The other thing that's really great is nowadays if people can get a record of it, a recording of it on the phone. I've made a number of diagnoses from people's cell phones, which is really something we never did 10 or 15 years ago. So the history is important. Then we do tests. So a CAT scan or an MRI is usually done to make sure that that person doesn't have a structural abnormality of the brain. And then an EEG, or a brainwave study. The brainwave study very often will show us an abnormality which may be focal or may be generalized, and that will first tell us that yes, this person has a predisposition to have seizures, and the EEG may also often tell us whether the seizure is focal or generalized, which influences the other testing that we might want to do or what kind of which drugs we would choose to treat.
And once it's diagnosed, how is it managed over time?
Right. So when someone first has a seizure, we have to decide whether that person would need to be treated with medication. And that's usually the first treatment is medication. And we determine that, so if they've had more than one seizure, almost always we would start medication. But if somebody's had one seizure, and we think because of other risk factors, for example, they had a traumatic brain injury, this person had a stroke, or they have a history of a brain tumor, then we would, even with one seizure, we might recommend that they start a medication. There are a variety of different medicines, many new ones, some that have been around for decades. And so we would then try to match the medicine to the type of seizure and the profile of the patient themselves.
We can kind of jump into our questions from our Facebook audience. How do you educate others that not all seizures are grand mal?
I think this is a very important question because most people, when they think about seizures, they think about convulsions, what are termed grand mal seizures, what we call tonic-clonic seizures. Those are all names for the same thing. But as I mentioned, seizures can range from something as small as just a jerk, a single jerk. So some people have something called myoclonic seizures, and those can be just a jerk of the shoulders. Now, most people who have those jerks have other types of seizures as well, but a seizure can be as small as that or as big as a convulsive seizure. The most common ones that we see are especially two different types of staring episodes. So in children, very often you'll hear about petit mal or absence seizures. So these are short seizures. They may last 5 or 10 seconds at a time. And the person is just out of it, and you may be talking and then they're right back. Right. And during that time when they're out of it, the EEG will actually show a spike wave pattern. The other type of staring spell is something called, what we used to call the complex partial, now we call focal with impaired awareness. So it's a brand new change in the, so if people are watching and your doctor has told you have complex partial seizures, the new name is now focal seizure with loss of awareness. But in those seizures, usually there's a warning. A variety of different things can be the warning. Then the person may stare and be unresponsive, but usually for a longer period of time, more like 30 seconds or 60 seconds, or even 2 minutes or so. And then be a little bit confused, sometimes with a speech problem or other confusional things in that period after. So again, the two main types of staring spells are absence or complex partial. The absence usually have no warning, brief duration, and they're right out of it. Whereas the complex partial, it kind of builds up a little bit. The seizure itself may last a few minutes, and then there's this confusional period afterward.
So in terms of medications, how do medications control seizures? And how often do seizures continue?
So we have a variety of different medicines. And in the past, you know, a lot of the medicines have different mechanisms of action. So there was always this thought, well, if somebody doesn't respond to one with one particular type of mechanism, you try to switch to a drug that has a different mechanism. But now we know that people who have medication-resistant epilepsy usually manifest pretty early. So the general guide that we use, which was developed by the International League, experts of the International League Against Epilepsy, says if somebody with seizures has tried 2 different medicines and they were used appropriately and titrated to a good dose and they didn't respond, that defines you as having medication-resistant epilepsy, or another term that's used is refractory epilepsy. And about a third of people with new onset seizures will develop refractory epilepsy. So it's important not to try 6 or 7 or 8 medicines before you really get to the more advanced kinds of treatment. So that's why we have places called epilepsy centers, where the staff are epileptologists. So these are neurologists who have done additional training in epilepsy and are aware of all the advanced kinds of treatments that include devices and surgery, maybe clinical trials of new medication, or really, in some cases, just optimal ways to make a correct diagnosis and to figure out how to match the medicine to the person exactly.
And then what options would be available to a patient who may not respond to the medication?
So at an epilepsy center, the main things that we would do, especially early when we first see a person, is we may bring them into our epilepsy monitoring unit. So this is an inpatient unit where people are hooked up on EEG and they have electrodes. They're also on a video camera constantly, and we often take down or withdraw some or all of the medication to try to bring seizures on. So this is an unusual situation for the patients because they're normally trying to avoid seizures completely, but now we're in this situation, we're trying to bring a seizure on. But then, because we have the EEG and the video during the seizure, we can actually study exactly what happens second by second and really precisely map the part of the brain where the seizure comes from, determine which type of seizure it is, and maybe come up with new treatments that way.
And talking about an epilepsy center, if you just tell me a little bit more about what an epilepsy center is and tell me about the epilepsy center at the UC Gardner Neuroscience Institute.
Sure. So an epilepsy center usually is staffed by experts who are experts in epilepsy, neurologists with additional training in epilepsy, but we also have highly trained EEG technologists, specialized nurses. Usually there's a surgeon for the epilepsy surgery who's specially trained in epilepsy surgery because it's a very complicated surgery. It works quite well for people that are carefully chosen, but it's not surgery that any neurosurgeon would want to do or could do. And then we also have neuropsychologists because we do neuropsychological testing. That helps us define the part of the brain that's dysfunctional. So in some cases, for example, if somebody has seizures from, say, the left temporal lobe, the left temporal lobe of the brain controls speech and memory. And on the neuropsychological testing, we may be able to say, oh, this person has an IQ of 100 and is really average in everything, but their ability to remember words or lists of words is way down, in the 60, 50th percentile. That may match with where the seizures come from. So sometimes we can see brain dysfunction in an area that seizures come from, So it's not the actual seizure itself, but it helps us locate the part of the brain where the seizures come from.
Can an adult with no history of seizures develop epilepsy?
Yes, most certainly. In fact, when we look at the ages that people develop epilepsy, the most common is in childhood. Then it dips down, but there's still plenty of people that we see in their 20s and 30s who've developed epilepsy. And then the incidence goes back up in older age, probably related to things like brain tumors, strokes, or even Alzheimer's. So Alzheimer's actually gives you a slight increased risk of having seizures if you have Alzheimer's. But the other way doesn't work. So people with epilepsy are not at higher risk of Alzheimer's, but people with Alzheimer's are at higher risk of epilepsy.
So what is the purpose of UC Health's epilepsy monitoring unit, and where are they located?
We have two different epilepsy monitoring units now. One is at the UC Medical Center here in Clifton, and the second one is at Westchester Hospital in Westchester, Ohio. They both really function pretty much the same, although more the advanced treatments that relate to devices and electrodes that are implanted into the brain to study seizures, that kind of work goes on at UCMC. But we evaluate people for seizures, sometimes new onset seizures, people who have medication-resistant seizures, or people who have unusual episodes and the doctor's not sure whether they're seizures or not. We, again, have these advanced techniques that we can do for EEG and the video, and we're able to really define. So probably multiple times per month, we'll get people come into our epilepsy monitoring unit who've been diagnosed with possible or probable epilepsy, and we find that they don't have epilepsy. They may have a heart problem, or they may have narcolepsy or a sleep problem, or in some cases, people have stress-induced episodes that look like seizures. We call them psychogenic non-epileptic seizures. But again, it's very important to identify those correctly, because these are people that are often taking a lot of medicine, and the medicines have a lot of side effects. And when they undergo the evaluation, we say, the good news is you don't have epilepsy, and you don't need to take these medicines. What you have is very real, and we need to treat it. But it's actually a good thing for many of these patients.
And how long is someone monitored on an EMU?
In the EMU, the Epilepsy Monitoring Unit, our average is about 4 days. So some people may go just a day or two if we can make a diagnosis. Like we've had some people in our monitoring unit who may have 20 seizures in the first day, and then we can make a diagnosis from that. Other people may go a little bit longer because what we want to see the seizures. So for some people it takes longer. We always sort of joke that the best treatment for seizures is to come into the epilepsy monitoring unit, because people are in the hospital, they're lying in bed, they're not at work, they don't have a lot of stress going on, and even though we reduce medicine, sometimes people don't have seizures for several days.
So another question we have from someone from our audience, what is VNS?
VNS is the other name for it is the vagus nerve stimulator. It's a device that we use to treat epilepsy. Generally, we use it in people who haven't responded to medication. There's like a pacemaker device that's put underneath the skin of the chest, and then there's a wire that goes up the neck onto the vagus nerve in the neck. We program the stimulator, and typically when we first start it goes on for 30 seconds and off for 5 minutes, so it cycles off and on all day long. In addition, patients have a small magnet. Very often they wear it in a bracelet type arrangement, where if they're in that 5-minute interval where there's not a stimulus, but they feel a seizure coming on, they can put the magnet over the device and immediately get a stimulation from the vagus nerve stimulator. We probably have, I don't know, I'm guessing 150 people that have the vagus nerve stimulator. It's a very helpful device. We find it most effective in people who have different kinds of seizures, but it seems to be very good at reducing the frequency of the grand mal or tonic-clonic seizures. But it's uncommon to see people get completely seizure-free from vagus nerve stimulator. It's also very helpful in people who have a lot of side effects with the medicines, because unlike the medicine, it doesn't make people dizzy, it doesn't make people drowsy. It is a procedure. You have to get it implanted. It's a small procedure, but it is a surgical procedure.
Does VNS treat vocal or visual issues?
Well, it treats seizures, And in some people who have seizures from the occipital lobe of the brain, that you can have visual seizures. So it would treat any type of a focal seizure. I'm not sure what the question was asking about, the vocal seizures, yeah. But when people get the stimulation with a VNS, they lose their voice temporarily. So a lot of times their voice turns into a whisper when the stimulus is on. So that's what most people would consider kind of an annoying side effect, but not really a bad side effect. Usually that doesn't stop people from continuing to use the vagus nerve stimulator.
So another question we have from our Facebook audience, do you feel exercising is good for epilepsy?
In general, I think exercise is really good for epilepsy for several reasons. Number one, sleep deprivation can be a trigger for seizures. And when people exercise, they generally sleep better. Another thing is that exercise is also kind of a stress-reducing thing, and a lot of people do also have stress as a seizure trigger. Now, there are unusual cases where exercising and breathing really heavily may trigger seizures in some people, but I would say that the number of people that get seizures triggered by exercise is way overwhelmed by the number of people whose seizures would benefit from exercise. But I think all patients need to talk to their doctor to make sure any kind of an exercise regimen that they start is right for them.
So we have another question. Can you talk about the research into CBD as a treatment to epilepsy? Is CBD oil something you can buy at stores or online? The same CBD you would get from a physician?
This is the most common question I get asked in clinic every week. So, when we think about medical marijuana, or marijuana in general, there are really two main components. There's THC, and the THC is the part that gets people high. So that's what makes people, giggly and eat more and do all those things. And then CBD is the other part of it. So CBD doesn't make people high. People don't. There's nothing that looks that people really want to repeat it for, or it doesn't make them feel high. So CBD, we take out all that THC part. So there's three different ways that people can get CBD for epilepsy. So the first is there's an FDA-approved product. Now, we were part of the clinical trials here at the University of Cincinnati at the Gardner Neuroscience Institute. This was a pure CBD product where almost all the THC was taken out, and we did multiple studies in people with really difficult to control seizures. And there was a dramatic response. The average person in the study, who had tried usually 6 or 8 medicines before, cut their seizures by 50%. That product, it's called Epidiolex. It's a medication that's now, it's a prescription medicine, is available, and we've prescribed it for quite a large number of people, and it seems to work really well. The problem is it has a very narrow indication from the FDA. There are 2 epilepsy syndromes. One's called Lennox-Gastaut, the other one's called Dravet syndrome, and those are the 2 syndromes it's approved for. Now, physicians are able to write medications off-label, but very often insurance may not pay. So we're in a situation now where there's a lot of people in my clinic who I would like to prescribe that for, but their insurance may not pay for it. That leads us to these alternate forms. So people can go online and try to get CBD. But part of the problem with that is that the online, very often, you don't know exactly what you're getting. It's often not regulated. You don't know the content of CBD that's in it. You don't know how much of the THC has been taken out. So you're really kind of using a medication without a lot of guidance about it. In Ohio, in the state of Ohio, we now have a medical marijuana program. But my understanding of what's available in the dispensaries now is usually a combination of THC and CBD, and it's usually flower products. So they don't have oils, they don't really have edibles, at least that I'm aware of in the last few months. So again, you're using a product that potentially could help your epilepsy. I'm not saying it doesn't work, but it's a little bit less well regulated. The most important thing is to talk to your doctor. Getting medical marijuana or getting CBD online or getting CBD from a health food store where a lot of times you can find it it's important to talk to the doctor because CBD does have potential drug-drug interactions. It can interact with other seizure medicines that people are taking. So it's important just to be honest and open with your physician so they can help make some adjustments with that. If people have more interest in it, I'll actually be giving a longer talk about this whole topic at our symposium on November 2nd on Saturday.
Excellent. Another question we have from our audience: if someone witnesses another person having a seizure, what should they do or not do?
That's a very important question. Seizure first aid. So if it's a tonic-clonic seizure, the most important thing is just to roll the person on their side. Do not put anything in the person's mouth. This is something that people used to talk about before, but the most common problem that you get when somebody puts something in somebody's mouth who's having a seizure is they may break their teeth. So you roll the person on their side so they don't aspirate. You let the seizure end. Very often, if the person wakes up, and they usually will wake up 5 to 10 minutes after even a tonic-clonic seizure, they may not need to go to the hospital if it's somebody who's had seizures before. But if they've hurt themselves, they probably need to go. If it's a first-time seizure, they would need to go to the hospital. If somebody's pregnant or has diabetes, those are the things where you really that person probably needs to go to the hospital. But the second type of seizure, which is what we talked about before, the complex partial seizure, where people stare, in those the person is confused. So what you don't want to do is try to hold them down, because very often people may get agitated, especially in the part of the seizure after what we call the postictal or post-seizure state. So they're out of the seizure, but they're confused, they don't know where they are, and if you try to hold them, very often they'll lash out or may hit people. Mm-hmm. But the most important thing is to try to guide that person away from any dangerous things. So if they're, for example, in the street, you may want to try to gently guide them off the street and then try to just talk to them gently and try to find out, is this the first episode? Do they take medication? Do they have a phone number of somebody that they want to call? And again, if they've hurt themselves, if it looks like it's a woman who's pregnant, or there's other questions like that, then it's important to call 911 and have them transported to a hospital.
So looking at the technology we have today, what are your thoughts on using the Apple Watch along with other apps to monitor seizures?
This is a great question because it's actually some research that we're starting pretty soon. So I think there are devices now that are seizure detection devices that I think can be very helpful, but especially if somebody has the bigger tonic-clonic seizures, because tonic-clonic seizures at night can be dangerous. It's rare, but people can actually die during a seizure, and the most common scenario is a tonic-clonic seizure that occurs at night when somebody's unmonitored. And for example, they may go face first into the pillow and not wake up. So if it's important that you want to just detect tonic-clonic seizures, the watches and the other devices, there's something called the Empatica watch, there's a variety of other companies that make watches. What we're interested in our research is actually thinking about how can we predict seizures, and can we use things like change in heart rate, sleep deprivation, measures of stress that we can get through devices to try to predict when somebody might have a seizure. Because many of our patients say, they may have 1 or 2 seizures a month, and other than the 20 minutes around those seizures, they're fine. Everything is great. If they knew when the seizure was going to happen, it would make a huge difference in their life, because they could say, hey, look, I have a high probability of a seizure tomorrow. Maybe I'll just call in sick ahead of time so that I don't have a seizure at work in front of people or doing some kind of dangerous work. So we're very interested in seizure prediction, and we think some of the newer technology may be helpful in working on that. So this is one of the projects that we're working on now at UC, at the Gardner Neuroscience Institute.
Another viewer is wondering, can you have a seizure and still be aware of what's going on?
So the answer to that is yes. If a seizure involves just a small part of the brain, say for example, the area of the brain that controls movement in your hand, you can have a jerking of the hand like this, and it wouldn't involve speech or awareness, and you might be completely awake during the seizure itself. So they're not especially common, but certainly we've seen plenty of patients who have what we used to call simple partial seizures, but now we call focal seizures with retained awareness. So it's actually not uncommon to see that.
To come back to the Epilepsy Center, are people being referred to an Epilepsy Center soon enough?
This is a very important question again. We've done surveys, and there have been a lot of experts in epilepsy who've gotten together to produce guidelines. And the guidelines say that within 3 to 5 years, if you've had seizures and you're continuing to have seizures despite medication, within, say, 3 to 5 years, you should be referred to an epilepsy center. When we did surveys of people who came to the epilepsy center, the average was about 18 years. So there's a big disconnect there, where we think people should be coming to an epilepsy center in 3 to 5 years, and the average for epilepsy center or surgical evaluations is 18 years. So people are not coming to the surgery center soon enough, or the epilepsy center soon enough. So I think it's very important that doctors recognize this and patients recognize it, so that we can really get the best care. Because once you've failed, as I mentioned earlier, once you've failed 2 medications, the likelihood that the third medicine is going to work is only about 5%. So that's when you really need the experts. You need the people who really know all the different options for somebody with difficult to control seizures.
With the research we have here at UC Health and everything that we are doing on the academic side, we have a question. Are there any research studies currently being conducted at UC Health for seizure prediction?
Right now, we're in between seizure prediction studies. So we completed one that was done about 2 or 3 years ago, and we've applied for funding, and we're sort of looking at that. But we're planning some seizure prediction studies in the near future. But right now, this moment, we don't have anything ongoing. We do have some clinical trials of new medications for epilepsy, and there are a variety of other studies that we're doing, especially to look at SUDEP, or sudden death in epilepsy, which I mentioned is pretty rare, but obviously a devastating effect of epilepsy.
Another question we have from our audience, how do you determine if a patient is a candidate for epilepsy surgery, and what surgical options are available?
This could be a really long answer, but I'll try to give the short version of it. So the most important thing is that we can identify the part of the brain where the seizures come from, precisely identify, and be sure that that area of the brain is far enough away from areas that control movement, sensation, speech, and memory, so that taking out that area of the brain or ablating it with the laser, which is the newest technique that we use, would not produce a predictable untoward effect. Like any brain surgery, there's always a risk. But if we know that, for example, the seizure focus is right next or right on top of the speech area of the brain, we would not operate. But we now have newer techniques where we can do devices that stimulate. So some of the newer epilepsy, you have to have an epilepsy surgery to get the device implanted, but it's not epilepsy surgery that actually takes out the seizure focus, but it can modulate the seizure focus using these implanted electrodes to be able to control seizures that way. So there are lots and lots of options. And again, I'll put a pitch in for our patient symposium, because we'll have a whole 30-minute talk about the approach to epilepsy surgery, who might be candidates, what we do, and other options like new devices.
And we will come back to that when we wrap up. Another question we have is, do patients need a referral to an epilepsy center, or is there something they can self-refer to?
In general, we like to have a referral, but I think if someone is seeing a neurologist or and wants another opinion, we certainly would see that person. But we also have a new onset seizure clinic, so we have our epilepsy specialists have special visits cut out. So if somebody has their first seizure or has episodes that might be seizures, and their doctor, who's not a neurologist, say is not sure whether this was passing out or fainting or some other kind of an attack or a seizure, they can get an appointment very quickly with one of our epilepsy specialists to evaluate that. But we're happy to see any patient with epilepsy, if they're medication resistant, if they think, well, I've tried 5 or 6 different medicines, and now all of them give me unacceptable side effects, for example. we're happy to see our team of epilepsy specialists can see any of those patients, and give our opinions.
Can you set up a visit for someone out of town to come to the Epilepsy Monitoring Center so that all the tests can be handled in a week or two long visit?
I think we could do that, yes. That's not the typical way that we do things, but I think if it was planned ahead of time, we certainly could do that. I mean, I've seen people from as far as Brazil or Colombia, South America, who've come for these kinds of an evaluation. We would have to set it up ahead of time, but we certainly, I think, could get our epilepsy monitoring unit, get evaluation, any MRIs or any other scans that we could do. We could certainly set it up, and I think that would be, as long as we did it ahead of time and we knew that all these things needed to be synchronized, we could certainly do that.
As we wrap up, tell our audience more about the symposium coming up.
On Saturday, November 2nd, will be our patient symposium. We do this symposium every year. It's got multiple different, we talk about new medications and medication options. We talk about surgery, surgical options. I'll be talking about CBD and medical marijuana and what all the options are there. And then we have a lot of time for question and answer, because many times patients may see their doctor and either the doctor's rushed or they don't have enough time, or they leave the doctor's office and say, gee, I wish I would have asked my doctor this particular question. So we really do have quite an extensive question and answer period. It'll be here at the Gardner Neuroscience Institute in the morning, on Saturday morning, and we'd be delighted to have, we always have plenty of people that come, but we have lots of room for more people, and I think you've given the website where people can go and register. Very important to register ahead of time so we can get the information on parking, location, and things like that to our patients.
Dr. Privitera, thank you again for your time. And thank you so much for our viewing audience today that joined us for this live Facebook Live. For more information again and registration information on the Epilepsy Symposium, visit uchealth.com/events/epilepsy 2019. From UC Health Marketing Communications, I'm Matt Martin. We'll see you next time.